Great. Thank you for joining us this afternoon. I know it can be tough to be the session after lunch. The afternoon kind of sleepiness sets in, so thanks for sticking with us. Although I guess the weather's bad outside, so you have a strong incentive to stay inside. I almost got blown over coming in. So. But welcome to our session today. We're the Patient Advocacy Panel. My name is Bryant Lin. I'm one of the co-directors of the Center for Asian Health Research and Education. I'm also a stage 4 lung cancer patient. Never smoked a day in my life. So I'm very pleased to present to you this panel today where we're going to talk about the patient perspective, talking about patient priorities, and hopefully influence some of the researchers and clinicians here to better understand what a patient thinks about research and treatment. So we have a great panel today. We have Keith Perry, Yulin Pan, Vicky Ni, and Perla Ni, and we're just going to go in order. They're going to talk about themselves and some of their thoughts, and then after we're all done, then we'll have a discussion afterwards with patients, with the audience encouraged to ask questions. So we'll start with Keith Perry.
All right, thank you very much, and good afternoon. It's a pleasure to be here to speak with you today. When I read about what Dr. Lin was doing, I actually reached out to him via email, and we managed to spend an afternoon, have a lunch together, and he was gracious to spend some time with me and then invited me to share part of my story with you here today. Like him, I was a non-smoker and had absolutely no reason whatsoever to believe that I would be a subject of lung cancer. At the age of 50, I was living a happy, healthy life, a very active, outdoor style family, 2 kids, wife, 2 dogs, you know, the usual. And I did not connect the dots whatsoever with the small symptoms that came up along the way. Because I'm used to being outdoors and active, small aches and pains really didn't mean much to me. They were something that were to be worked through, not something that were indicative of a life-threatening disease. So when I got aches and pains in my shoulder, I didn't think much of it. When I had a minor cough, I wrote it off as something that was part of my allergies. When I had difficulty running, well, I'm 50 years old. Running is hard. Let's move on. But it finally came to light that, yes, I was suffering from something. And when we found it, the answer was, sorry, yes, it is lung cancer. And that was literally the shock of my life and the shock for my entire family. And little did I know when I was hired into the School of Medicine almost 30 years ago that I would be putting my life into the hands of those people who I was supporting. It turns out that my care team actually was part of your speakers yesterday. So I have to thank them very much for the fact that I am still here. The major takeaway, the point that I want to make is that as a lung cancer survivor, I don't think we really put a lot of emphasis on the post-experience quality of life. The majority part is, well, let's treat them, let's make them healthy, and then let's send them on their way. But I can tell you, when I was told that I was a lung cancer patient, and when I was told that you are very likely to lose your lung as a result of your treatment, well, that answer was somewhat suboptimal to me. That was not an outcome that I expected or something that I was particularly looking forward to. Granted, yes, I wanted to be alive. I wanted to be here for my kids and my family, but I also asked the question, what does that life look like for me? Losing a lung and the active lifestyle that I had, I mean, everyone in my family is an athlete of some sort. Both my kids ran cross country and track in high school and in college. And my wife is an ultra marathoner. She ran the 100-mile Western States endurance race. And I'm thinking about, how am I going to engage with my family going forward with only one lung? Honestly, I want to point out that I think lung cancer patients are capable of much more than we give them credit for. And they need the encouragement to be able to engage in some of those opportunities. How much are they capable of? Well, a year after my lung removal surgery, my wife and I went for a bike ride to celebrate. We were going up Woodside Road, which is not a big road, but I was struggling because with one lung you struggle when you're going up a hill. And we passed a signboard on the right-hand side, and the sign said, Highway 1 closed next weekend, Santa Cruz Ironman race. And as we went past the sign, my wife turns, because she's in front of me, because she's always in front of me. She turns and she says, why don't you train for that? And the thought to me was, yeah, right. Sure, people with one lung don't do Ironman races. But we finished our bike ride, and over the next day or two, that thought just wouldn't go away. And so I had this dialogue with myself about, what if I tried? What's the worst thing that could happen? Well, you could drown. But what is the worst? I would be in better shape than I am now. I mean, you just survived lung cancer, you survived chemotherapy, you survived clinical trials of immunotherapy. What the heck? Well, let's give this a shot. And so I asked her, I said, were you serious about that? And she goes, sure, why not? And so I set out to train. And it was supposed to be only 12 months, 9 months of training or so, but then we had this little thing called a pandemic in the middle of all of that. Races got canceled, postponed, so it ended up being almost 2 years before I was able to go to the actual race that I had targeted, which was the Santa Cruz half Ironman race. Anyone here done a triathlon of any kind? Yeah, well, a half Ironman, just so you know, it's a 1 point. We got one. Oh, yay! All right, I saw a hand. So you were part of a relay. Fantastic. The swim is 1.2 miles in the open ocean. The bike is 56 miles along the California coast, and then you run a half marathon. So that's what we're talking about. And when I finally did have the opportunity to do it, I completed the course. I did it in the time allotted, and it was absolutely amazing. I did not think that it was possible, and I think it's a story that other lung cancer patients could be encouraged to hear. But you know what? I didn't stop there. I went ahead and said, what if I did a full Ironman? What would that look like? So I signed up for the California Ironman race, which took place in Sacramento about a year later. And yes, I managed to complete the California Ironman race as well. So, I just finished taking a class on campus from Tara Vanderveer last night. And one of the quotes that she shares with her patients is, inside every disappointment, there is an opportunity. And I had to reflect on that and my own personal experience. And I had to say, I didn't see it at the time when I was diagnosed with lung cancer. It's impossible to see something like that. But inside that disappointment, for me, there was an opportunity if we are willing to encourage people, if we are able to help open their eyes to possibilities, and to give them the right support and encouragement. Ironman has a phrase, they say, anything is possible. So, thank you.
Thank you, Keith. Next we have Dr. Yulin Pan, who's actually dialing in from Michigan.
Hello, everyone. Good afternoon. I apologize that I cannot be there in person. I really hope to be there to talk to people, but because of my condition, I cannot go today. So I will probably share something a little bit different from the previous speaker. Um, so so I work as an assistant professor in naval architecture and marine engineering at University of Michigan. So my research is in mainly in applied math and fluid mechanics. And recently, I also got very interested in cancer treatment because of my own situation. So I was diagnosed with stage 4 non-small cell lung cancer in the June of 2023, in my 30s. So I was a very healthy person before the diagnosis. I live a healthy life and I do not smoke and I exercise regularly. So it was a shock to both me and the doctor when they announced the diagnosis. So after that, my first line of treatment is chemotherapy plus immunotherapy. They used pemetrexed, carboplatin, and Keytruda on me. So unfortunately, that lasted only for 4 months. I think after 4 months, there was a almost explosive spreading of the cancer. So it metastasized to a lot more locations on my bones, and also there were innumerable lung nodules developed in both of my lungs. So so at that time, we switched the treatment to second line as amivantamab, which is yes, I forgot to tell you that my cancer is with the EGFR exon 20 mutation, which many of you know is a very difficult to treat mutation. So my second line is amivantamab, um, which was approved for the EGFR exon 20 patients, and I was on that treatment for a little bit more than a year to today. So in this 1 year with amivantamab, actually lots of complications happened. So last year in April, I had a fracture, bone fracture, due to the lesions on my lower spine. I know I was hospitalized for 3 weeks and did 10 sessions of radiation. And after that, I also developed brain metastasis, which I did radiation again. And in fact, just in the last CT scan, in February, they found that my cancer progressed again in my lung, and my main tumor became a few millimeters bigger. But there is one nodule that grew from 2.5 millimeter all the way to 12.8 millimeter in a 2 months interval. So and also I started to develop symptoms like cough and headache. So in the past 3 weeks, I'm trying to find a clinical trial to participate because there are really limited options for me as an exon 20 patient. The current plan is to participate in a clinical trial for the drug called PNG 461. That is a drug targeting the MTAP deletion, which is another mutation I have based on the tumor biopsy. So I hope that works. Um, so this is my situation. And the first thing I would like to say to the audience is that I heard lots of wonderful talks, and I know there are many experts in this field in the meeting. So if you know anything, any treatment that can benefit me, please let me know. I'm sort of in a critical point for my next line treatment. And I think down the road, because my cancer is everywhere, um, I would be happy to try anything that is possible, even if it is something that is in academia lab that is not available in industry at all. If I'm allowed, I'm willing to try everything. So I heard earlier in the meeting that people said so the industry are more interested in the well-developed approach, but early stage thing, which has great potential, are actually in the academia. So it is the same for my field. So, but anyway, anything, I think if I'm allowed to try experimental things in the academia lab, I'm very happy to do that. I know that's probably not allowed, but I think it should be allowed for some patients that run out of other options. So that's my hope for the future. And I would like to also bring up a point on from a patient perspective in terms of the exposure to clinical trial and in terms of what is the responsibility for a doctor to treat a patient. So I'm gonna elaborate a bit more on why on what I think. So based on my own experience, when I was first diagnosed, it was stage 4, but it was not that bad. I only have one metastasis out of my chest that is on my sternum, and I have lots of involved lymph nodes involved, but that is not what classify my case as stage 4. So, so so I did chemotherapy. As I told you, after 4 months, there was a explosive spreading of the cancer. So if I think back today, um, if I had the knowledge of what I have today at the time of my diagnosis, I probably will not go to chemotherapy as my first choice. I will probably go to a clinical trial with exon 20 TKI. So at that time, actually, there were several trials about furmonertinib, about samvosertinib, and about zipalertinib. There are all these options at that time, but I simply do not have that knowledge when I was first diagnosed. I could argue that if I go on the EGFR TKI at the very beginning, the outcome might be very different because I just have one lesion as my metastasis. It's likely that this TKI works very well and they kill all the my bone lesions, then I probably will be a candidate for surgery. But all these opportunities are lost. I cannot say that going to the chemotherapy is a mistake, but it certainly minimized, reduced the chance for me to get to become a candidate for surgery. So anyway, I think this is an opportunity that is already lost. And one reason for this is nobody educated me about clinical trial at the beginning of my diagnosis. So my doctor is a very good doctor in terms of following the standard treatment, but he doesn't think it is his responsibility to tell the patients something outside the standard treatment. So I think it would be great if we could educate the doctor to really think on the behalf of the patients, especially for someone like me that where the prognosis is very poor due to the exon 20 mutation. It will be very beneficial if from the very beginning the doctor keep me exposed to this opportunity for a clinical trial. At least let me know there's an option in addition to the standard care. So I think that would be benefit the patient a lot. So I think I'll just say this and we can talk later. Thank you, everyone, for listening.
And next up, Vicky Nee.
Hi, everyone. Is that on? Okay.
Yep.
It's an honor for me to be here to address all of these leading lights in the Stanford medical community. I guess in my disappointment is the opportunity to speak here today. And I'd like to especially thank Dr. Wakely, who has been the leader of my care team, and Dr. Vitsum, who was here yesterday. He's been at the forefront of my radiology. I think it was almost exactly 6 years to the day that I was first in Dr. Wakely's office. I don't know if you realize that, but it was the shock of my life, as Keith mentioned. And I think I'm here today because I'm sort of the poster child for non-smoker lung cancer. I'm female, East Asian descent, Chinese heritage, and I was diagnosed at the age of 48. And I do have a family history of lung cancer. 2 siblings in my father's generation had EGFR. So I guess I should have gone to Taiwan, is the answer. Here, of course, I didn't qualify for any kind of screening, being a never smoker. And I think the first thing I would like to say is that lung cancer is still generally perceived as a smoker's disease. And this is true among the general population, as well as clinicians, general practitioners on the front lines, really have not heard of non-smoker lung cancer. And this matters, at the time of diagnosis. In particular, my story illustrates kind of how this ignorance can affect the time to diagnosis. The patients are not aware of the symptoms and risk factors associated with the disease. The practitioners of the front lines are also not aware of these things. And then by the time that you experience symptoms, more often than not, you are stage 3 or stage 4. So in my situation, what drove me to look for medical advice was I had a pain in my right shoulder blade. And I'm right-handed. Seemed like it could be carpal tunnel syndrome. I was treating it with acupuncture, Tylenol, deep tissue massage. And, I'm not someone who cries wolf, and I tend not to, address my own pain. And I had 2 daughters to raise. I was a working mom. And so the last thing I needed was to go to the doctor. But eventually it got bad enough that I did seek medical attention from a pain specialist who took an x-ray of my neck looking for kind of collapsed vertebra. And it was only an incidental finding in the lower right that showed that my diaphragm was inflamed. And it was so incidental that at the time that I met with him to discuss the results of the x-ray, he didn't even mention it. He just couldn't really find the source of my pain. And it was a voicemail to me later. It kind of was like a niggling concern of his that led him to leave a voicemail to say, I saw this on your scan and you should just get it checked out. So, what does that mean? I have a busy life. We had a snow trip planned. Eventually I made an appointment. And next I saw a general practitioner who, having heard my history as a non-smoker, really did not consider lung cancer is even on the menu. And again, I was given an x-ray, which, as all of you know, is not as powerful as a CT scan would have been. I distinctly recall how he sort of was weighing the two, and he balled up the order for the CT scan and said, let's just do an x-ray. So fortunately, the x-ray showed a pleural effusion, which then led me to a pulmonologist's office. And by then, it was about 4 months into my sort of journey with this. And when I think back, I think it could have easily gone a different way. I could have easily been lost to lack of follow-through, because again, it was this indeterminate symptom. I never had respiratory symptoms. And it was only in the pulmonologist's office at Stanford where I heard the word cancer. That was the first time it was mentioned to me as a possibility. So this is all to say that I think that there's really a need to educate the public about the existence of this disease so that they can advocate for themselves, but also, make the people on the front lines aware that the medical community more aware of this. I can't tell you, every medical professional that I've encountered since my diagnosis, other than those here at Stanford, have never heard of it. They just assume it's a smoker's disease. The second thing I would say is that if I had a magic wand, I would like to see kind of a gathering of information on the clinical trials available to non-smoker lung cancer patients. I have been in treatment for 6 years now. I was diagnosed at stage 4. I was on a second-generation TKI, alectinib, and then for about 3 years, and then third generation lorlatinib for about 2 years. Then I tried a clinical trial, the NVL 655 Nuvalent trial. Unfortunately, that didn't work. I progressed within 6 weeks of that trial, and now I'm on chemo. So for those of us who are nearing the end of sort of FDA-approved treatments, what is foremost on our mind is what's next. And I think the truth is that it's not easy for a patient to navigate those choices, because you're at a treating institution, and even at a incredible place like Stanford is most familiar with what is at Stanford. And, to get information about the trials at other institutions, is quite daunting, let's say. And, how does one navigate that? How does one optimize, the leads that you follow? Because there's probably too many to, do on an individual basis. So that would be, my wish list. The third thing I would say is that since I'm up here and I'm on the community board for the FANS study, the Asian never smoker study that has been mentioned several times. And I just want to give a plug to the fact that they are in their final stages of recruiting both control subjects and lung cancer patients. So a very concrete thing you can do to further the ball in this area is if, for the control group, they're having particular difficulty recruiting those in the 60-plus cohort and the 80-plus cohort. So you don't have to have lung cancer. It's just if you have an auntie or a mother that's living in a major metropolitan area in California, they would qualify. You just Google FANS study and you can find how to enroll. And then for the lung cancer patients, they are looking across all ethnicities, Asian ethnicities, and age groups to continue to fill that cohort. You have to have been diagnosed within the last 18 months. So I think that's all I have to say. Thank you so much for your time.
Great, thank you, Vicky. And next, Perla.
Thank you so much, Dr. Lin, for organizing this amazing gathering of all you wonderful people. So my name is Perla, and my dad was diagnosed with stage 4 non-smoking lung cancer, and he had wonderful care here at Stanford, thanks to Dr. Wakely and Dr. Lin. They're one of the most dedicated, generous, kind, thoughtful doctors that my dad had the privilege of having. So thank you. In terms of our experience here at Stanford, my dad was really, he couldn't have found better care anywhere, I think. He had amazing doctors who came to visit him at the hospital, doctors that he really trusted. He had no problems getting labs, getting prescriptions, getting the Tagrisso discount, thank you. So we had wonderful experience with his care team. Dr. Bryant Lin invited me to say what could be improved, so I racked my brain. There's a couple of things that could have been improved, the patient experience. Not just here, but I think just overall, to your point, Keith and Victoria, in terms of like the patient experience of how to live. For my dad, it was also during COVID, so it was a time when we couldn't really all fit into Dr. Wakely's office. And so we really needed for him to tell us, what the diagnosis was, what were the medical instructions, and like everything had to go through him. And he was 80 years old at the time, and his English was not that great. And so we had to kind of just like trust that he knew what was going on. But, he lived a block away from us, and I wanted to make sure that he was, taking his medications on time. I wanted to understand how much time he had left over. I wanted to understand how we can plan family vacations. Was he allowed to go on vacations? And if so, how strenuous can those vacations be? What kind of medications did he need to take? So, these questions, to your point, Keith, about how to live is really important for the family, because we want to be there and support the patient and, make sure that we really make the most of the lives that we have together. I was worried about not knowing about the side effects of the drugs. Like, he had really dry skin. Is that, should I buy moisturizer for him? Is it like, what are the things that we can do to alleviate some of the symptoms, and what were the things that we couldn't? Towards the end of his life, he needed oxygen, and this is just, one of those pragmatic things where I did not know how to operate one of these oxygen things. You had these like nozzles, you could control the flow of oxygen, and I had no idea to turn it up or turn it down, and it would have been great, for me to probably, watch a video on how to do it, but I didn't even know like how much oxygen did he need. So I was like basing it upon in his kind of saying, oh, I still feel tired, so I would then increase kind of the oxygen level. And then, to your point, Victoria, about clinical trials, it would have been great to see if there was other clinical trials in other places. But, you can go on the web and there's a lot of information, but you're just like, I have no idea how to understand if who, would qualify for these things. So in terms of just brainstorming some solutions, I don't know if these are feasible or not, but would love to have easier medical records sharing so that I could see with, my dad's permission what was in his medical records, the doctor's notes, so that I could see how it could support his treatment. It would have been great to, I don't know if there's a care coordinator or a nutritionist to ask those questions about side effects and diet and what he should be eating, what he should be avoiding, because it could also work against his treatment. And then lastly, some sort of like more tailored clinical trial information, just like news about new clinical trials and who might be eligible. But I think overall, I think the treatment here at Stanford was really A+, and I don't think my dad could have had a better treatment anywhere else. So I'm just really grateful for the people here in this room, especially Dr. Vicky and Dr. Lin. Thank you.
Well, thank you to our panel. I'm gonna open up, before we open up to questions, I'm gonna ask you about different areas. So we can start with screening and awareness, and then we'll talk about treatment, then clinical trials, and if we have time, survivorship as well. So talking about, I think many of you have mentioned screening or awareness. Part of the effort today, of course, is to raise awareness. Dr. Louis talked about potential screening tests. Right now, recommendations. Right now, we have no guidelines for screening. It's not covered by insurance. So obviously now you know what you know, and before you were diagnosed, you weren't aware of it. What are your thoughts about how to approach that? It's people will have to pay out of pocket. We don't have one body that's saying, like the United States Preventive Service Task Force saying, okay, this is the age when you start, this is who needs to get it. But obviously it's very important, right? If I were diagnosed at an earlier stage, that would be incredible, right? I would have loved to get diagnosed at an earlier stage. We'll go maybe one by one. Keith, since you were kind of an earlier stage than some of the rest of us up here, what are your thoughts on screening and how should we approach that with patient awareness? What should we do?
What I would say in my experience is I would have been heavily dependent upon my medical provider to help connect the dots, because clearly I had no clue that all of these randomly associated symptoms that I was experiencing had any connection whatsoever to each other. And so as I was, complaining about the cough to my primary care physician, or complaining about the neck, which I ended up getting an epidural shot, not an epidural, but a cortisone shot in the neck to try to treat that. If it hadn't have been for a random family vacation, honestly, we might not have found this for a while longer, because it was only the fact that I had a pain in my back on the way home during the transatlantic flight, and I happened to mention that. My physician said, "Oh, you had chest pains during a plane flight? That's possibly a sign of a pulmonary embolism." I said, "No, it wasn't chest pain, it was lower back pain." He goes, No, we need to look for something else." And so we did a test for a possible pulmonary embolism, which came back, and then, he said, "Okay, let's just do the CT scan." I don't know if he was connecting the dots in the background and just wasn't saying anything to me because he didn't want to panic me, which it would have panicked me. But, I consider it almost serendipity that we found it. Now, it was in a bad location, which caused the loss of the entire lung, but it was also in a bad location, which caused early symptoms, which I might not have otherwise noticed. So, good news, bad news, good news, bad news. Take it which way you want. Glasses half full, glasses half empty. I'm still here. So, I would have been completely 100% dependent on my medical provider to help me put the pieces together of the puzzle.
And Vicky, as you said, a lot of people you've talked to who are at Stanford that you've spoken with are not even aware that non-smokers can get cancer. What are your thoughts on, screening and awareness? How can we make a difference?
Well, I think in the short term, it is just awareness in the general population, and to sort of get people exercised about this. Following the lead of Taiwan, I think, would be a very, at least to my eyes, a straightforward sort of way to go. Family history seems to be a very big deal. And when I was diagnosed, I recall people saying there was no genetic component. And, here we are 6 years later, and clearly there is something driving predisposition. I'm telling all my family members, go to Taiwan if you need to, but do it at age 45 or earlier because of our family history.
So Perla, you're the daughter of a
Yes.
lung cancer patient. So what are your thoughts on
I have been
screening?
trying to get screened, and it's really impossible. I mean, my primary care doctor is at Palo Alto Medical Foundation. I spoke to her 2 months ago, and she said there is no genetic basis. And I said, "So how can I get screened?" She's like, "You can't get screened." And she didn't even say you can self-pay, right? So it was during winter, and a lot of people were coughing, and I had a slight cough. So I said, I've been coughing. Can you get me screened if I have a cough? And she said, "I can get you an x-ray if you are coughing, but that's not lung cancer screening." So I got an x-ray, chest x-ray. It was normal, but it's not a CT. So I think I need to go to Taiwan next.
Well, I think Stanford the cash price is reasonable at Stanford I've heard, for CT screening if you're willing to pay out of pocket. But Dr. Pan, what are your thoughts on?
And so I didn't tell you earlier about my story of diagnosis. At the beginning, I just had some rib pain and chest pain. So I went to the hospital to see my family doctor several times. It was not taken seriously. So from the time that I first went to the hospital to the time that I was finally diagnosed, that was more than 6 months. So I went to the hospital several times, but they would say, "Okay, it's probably some injury. Even if we do an X-ray or CT scan to find something on the bone, we cannot do anything." So they even didn't do any X-ray for the whole 6 months, even if I went to the hospital several times. So eventually, they decided to do an X-ray, and they found lots of pleural effusion. So I was then hospitalized and did lots of checks. So the CT scan showed lots of enlarged lymph nodes and some nodule in the lung. And even at that point, the doctor said to me, it cannot be lung cancer. You are below 40 and you never smoke. It cannot be lung cancer. The worst case scenario is some type of lymphoma. So that is what I experienced, but it turned out to be lung cancer, stage 4 lung cancer. I think in terms of making the situation better, it is not only to educate the public for the awareness of this disease, it is also to educate the doctor on each level to be aware of this, especially in today's society where the cancer rate rises rapidly. So the doctor should be aware that there is a possibility for this. Even I'm not in the screening population, that I live a healthy life and I don't have a family record for this. I think it's important to educate everyone. So nowadays, lots of my friends in China, what they do is that they go back to China to get tested, like people in Taiwan. I would argue also we need some way to make these screening tests affordable by many people, by everyone maybe. So I don't know how to make that happen, but I think that is a very necessary thing to do.
We've had various types of treatments and ideas and conceptions about them, and then also there's the kind of fuzzy line now between standard treatments or treatments that are approved and clinical trials. Keith, I believe you're on the advisory board for Behringer on clinical trials. Would you give us some thoughts from that perspective?
Sure. What he's referring to is I got connected to Boehringer Ingelheim as a patient representative for a project that was looking at clinical trials and what clinical trials could look like in the future. And so looking at societal changes, technology changes, what could help enhance clinical trials and what may actually detract from conducting clinical trials. And Victoria, I mean, the comment you made just about education around clinical trials, making people aware that these are available and just the simple opportunity to participate in a clinical trial. I was diagnosed back in 2018, and the standard of care at the time was exactly what I received, but I participated as a subject in a clinical trial, which has turned out to be have very positive results. And so clinical trials are essential in terms of being able to change what the standard of care is going forward. And as I got connected with more of the science around clinical trials, I actually said to my wife at one point, I was like, boy, I wish I'd have gotten this 5 years later, because the options now are so much better than they were when I got it. Of course, I didn't really mean I wish I got it. I just meant if I could move the time frame, if I had to, the opportunities would be different. But clearly the technologies and the techniques are changing so incredibly rapidly in the field that it's almost blindingly difficult to keep up with it.
And Vicky, you mentioned, having a database of clinical trials, and, it's so confusing, and I dare say, as a non-oncologist, it's confusing for me as well. On the other side, what do you think about patient involvement in designing and creating clinical trials, especially for someone like you who's, kind of reached, done all the kind of standard approved treatment already? What are your thoughts on getting patients more involved in the clinical trials themselves other than as subjects?
I mean, I think there's a lot of enthusiasm for that, especially in the non-smoker lung cancer community. We are living longer, and we are living longer on stage 4 with a reasonably good quality of life, and we have the bandwidth to take on these sort of projects for the greater good. I think in earlier times, maybe people were just like too tapped out and too much, fighting the fires. But, for those of us who have stage 4, we actually do have periods of respite where, things are stable and we can focus on other things. So, for each of these subtypes, genomic subtypes, there are patient advocacy groups who have organized themselves either formally or informally. And thanks to social media and Facebook and whatnot, there is a body that you could access and sort of ask these questions to. So if it's not happening already, I hope it does.
And then, Professor Pan, you're as a non-medical researcher, I think you're aware, though, of the kind of research funding environment. And you alluded to this earlier about a comment I think Dr. Gray made about how things are funded. What are your thoughts, especially as you have a less common mutation, what are your thoughts on, patient involvement and funding of research and clinical trials?
Please let me say something from my perspective of having a rare mutation. I think I really hope that the clinical trial could help patients in the sense that it could allow patients with rare mutation to participate. For example, there are some drugs for the EGFR mutation in clinical trial, but many of them exclude exon 20. So even for drugs that have some efficacy for exon 20, sometimes the company will just stop the trial because the data is not that very good. I would say it's for the company, of course, has a right to do that based on its own right. But I think for exon 20 patients, this is a really devastating situation because for this mutation itself, we do not have many options, and then we see lots of clinical trials closing, which it's a very hard situation for us. So in terms of research funding and connection between the industry and academia, I think what I really hope is that, like I said, if I'm running out of other options, I could try very early stage things that only exist in lab. So I think if that is allowed, maybe we patients could have a better opportunity, and also the development of a novel drug could be accelerated because there will be some population of patients that would be willing to try these experimental things. So for patients with stage 4 cancer and running out of options, I think there's nothing to lose to try these things. And also it could have early data for some experimental drug that is in the very early stage.
And Perla, your father passed away after a few years of lung cancer, and you mentioned on your slide, research and things like that. What are your perspectives on that? Your father was 80 plus at the time, but sounds like there would have been maybe some interest there if there was something accessible for your father. What are your thoughts on kind of research and clinical trials and patient care?
But I remember, going online, trying to find different research clinical trials because I wanted to learn, I wanted to understand just what was it about, what were the risks. And so it was really hard. I mean, to your point, it's really hard to read what they're trying to say. So it would be great to just have some resources that are available in plain English, normal people's reading level, to just say, like, here are the ages of people who would be eligible. Here is, where is the location? What is the commitment? Just very plain English, really simple website with a listing of information.
You also mentioned high out-of-pocket costs for Tagrisso.
Yes.
and you had to do the manufacturer's rebate discount.
Yes.
Thoughts on, cost of care and accessibility?
I mean, when we initially saw the cost of Tagrisso, we were just like in complete shock. Like, how can anyone afford this, right? So, luckily he got the discount, but, can't imagine, for people who don't have, a doctor who's willing to write them a note or who actually kind of, takes the initiative to write to the manufacturer and request this discount, like what that sticker shock must just be like, oh, I can't afford this. I'm not going to get this drug, right? So, for those of you guys who are here in industry, it would be great if there were actually like real prices for drugs rather than some, artificial price and then the actual price that people pay. So,
let's move on to survivorship. We have kind of two examples potentially. I know survivorship can be somewhat of a charged term and word there, but as Vicky, you said, people are living with stage 4 cancer are living longer with higher quality of life. What are your thoughts on what can be done to further improve that quality of life?
Short of running Ironman.
Not for everyone.
Yeah. That would decrease my quality of life. I can tell you, if I had to wake up and run, I'd be like, forget it.
I would say it's different for everyone, right? Sure. What a diagnosis like this does is it really focuses you on your priorities, and anything that is not meaningful to you or is, toxic to you, it has to fall away, just, kind of by necessity. So I think it differs, on the stage of life. For me, I'm still a mom, probably a mom first above all else. So, the priority for me was very clear to, accompany my girls as long as I could. They're 18 and 20, and at the time I was diagnosed, they were 12 and 14. So one of my goals was to see my youngest graduate high school, and I think I'll be there in May for that. You have to keep active for sure. Everyone says that, and it's so hard when you're suffering from side effects, and sort of the motivation to get up off that couch is just so difficult. And so having a support network is essential. I always say that people have to take me out for a walk, So, having that community to take me out for a walk is really important.
Keith, any words on that?
Yeah, I'm going to echo some of what Victoria said, which is when you get that first diagnosis, your world becomes tunnel vision. Like she said, everything else falls away. It becomes a day-by-day experience of just getting to tomorrow. You don't have the luxury of being able to think about much beyond tomorrow. And I was lucky enough to be, one of those people that has beaten the odds, at least so far. When I had my conversation with Dr. Neal and asked him, I said, I was still so new to the concept. I said, what are the odds? What are my chances of surviving this? And he wouldn't tell me. And guess what, Dr. Neal? There's this thing called Google. He sent me home, and my wife and I both got online, and we looked it up. And we said, 25% that will be here in 5 years. Are you kidding me? 6 years later. But at some point you start to, if you're lucky enough, you start to look out from under the covers and say, well, what could life look like afterwards, if there is an afterwards? And trust me, there is no true afterwards. I am a cancer patient for the rest of my life. I will always be a cancer patient. Every time I cough, my wife looks at me and kind of goes, Every time I get an ache or a pain, I have to ask myself now, is this something or is this nothing? It changes absolutely everything about who you are, and it changes everything about who your family is. And if it weren't for my wife and my kids and my wife taking me out for walks, I never would have gotten nearly as far as I did. And I had to ask her every time, would you please slow down? I can't walk that fast. Remember, she's the ultra marathoner, so all those walks, they were a challenge. But I think in the back of her mind, she knew what she was doing. So, there's still 75% of us that don't make 5 years. But for those that do, it's the question of what does the time after that look like?
Thank you. I'm going to, in the last 5 minutes, I'm going to open it up to questions from the audience or comments. Oh, wait, there's a microphone, yeah.
So thank you so much for this conference, Dr. Lin, Dr. Wakely, and others. So for the medical establishment who are aware of never smoker cancer, have they put forward any sort of screening guidance? Let's say in particular, if you have a family history, either a parent or an uncle who was a never smoker, had lung cancer, what is low-dose CT suggested, or once a year, what age? And then I was wondering, well, what is the cost in Taiwan, or that Stanford you can pay out of pocket?
So yeah, I get, as a primary care doctor, I get this question all the time. Dr. Louie mentioned her recommendation was 45 for women, 50 for men, low-dose CT if you have a family history or some other risk factor. We don't have any guidelines right now, and this is part of the challenge in the U.S. Historically, guidelines for small percentages of the U.S. have not generally been created, in large part generally, like especially in the U.S. Preventive Service Task Force. They tend to look at things very broadly, looking at huge chunks of the population and not necessarily specific parts of the population like Asian populations. We make up of 7% of the U.S., and out of that 7% are Asian, 3% are Chinese descent, and a couple more percent are of East Asian descent. So relative to the U.S. population, it's still a relatively small percentage. So that's been the challenge. But there's absolutely a need because guidelines push insurance coverage and push awareness, which increase our screening. I heard from Dr. Louie that Stanford does, I don't know the price, but does have some reasonable price for low-dose CT screening, but you still have to have a doctor's order. So in some cases, like in Perla's case, some doctors won't order it for you because they're not aware that you're in a risk group. They're not aware of the talent study from Taiwan, which showed such a high detection rate, 2% detection rate in that at-risk population, which is incredibly high. If you remember, in a smoking population, the detection rate's around 1%. So in that study, they were over 2% in terms of looking at people who got the CT who ended up being diagnosed with lung cancer, and that was a never smoker group. So yeah, it's a great question. We don't have standard guidelines. So yeah, you do have to rely on your primary care doctor in the most part for their awareness and to be willing to order this for you. I'll tell you this story. A friend of mine heard that I got diagnosed with lung cancer, and he emailed me and he said, oh, my parents were diagnosed, so actually I went out and got a CT scan myself, and he found a Groupon to pay for it because it's not covered by insurance, and it cost him $200 to do that. So I was quite surprised. Yeah, well, actually, one of my patients went recently to a radiology facility, I think Silicon Valley Diagnostic Imaging, and got it for $150. So there are even in California, there are little nuggets of, of bargain pricing out there if you know where to look for them. But you still need a doctor's order, so that's important. Yeah.
I'm sorry I missed that session on the screen, but once you start at 45 or 50 for men, how often do you do the low-dose CT?
Yeah, so I think she recommended every 3 years to begin with. So, again, we don't have great guidelines. We have that big study in Taiwan, but, again, so for like smoking screening, we do it annually, right? But the great thing is Dr. Louie does run a great clinic on screening So you can go talk to her or one of her colleagues to talk more about that. She runs a great clinic on lung cancer screenings. They have a team that works on this very issue. But it's challenging. It's not that straightforward. Again, we recently talked to Senator Hirona's office about this very issue, so hopefully we'll move the needle on insurance coverage.
Thank you.
Time for one last question. Okay.
Has anybody joined supporting group such as GoTo Foundation?
Yeah, actually, it took me a while to honestly get up the courage to go, but I did get connected with GoTo. And it was, as far as me progressing and coming to grips with my situation, it was absolutely fundamental. I wished I had found it sooner. I wished I had found it when I was first diagnosed. Though there are multiple organizations that are similar, where if you're a patient, that you can get help interpreting some of these diagnoses and alternatives, and spend more time with someone who specializes in that area, but on behalf of the patient. I have been thoroughly impressed with what they can do for a patient outside of the medical industry itself.
I actively follow a group called ALK Positive, and I am also, I participate in a lot of GoTo Foundation events, but ALK Positive for me is the most kind of rewarding place for me to go. It's very scary to be part of a cancer group, support group, frankly, because there's bad news and there's good news, right? And but because it's more tailored to my situation, and you have people who understand your situation in a way that others do not. So the other foundations, like GoTo Foundations, cover all kinds of lung cancer, including smoking lung cancer. So it's just a broader and less focused group.
Dr. Wakely was kind enough to have me invited to a GoTo coffee, is it called a salon or fireplace chat?
The living room.
Living room, that's what it is. Living room, yeah. Which is held, is it monthly or?
Yeah.
Every month, yeah, so definitely. And there's one more question.
Hi. First of all, I want to really share my appreciation for this being the final session of this incredible meeting, because I think there's something very important around the patient advocacy in terms of raising the awareness and then having the result be increased funding, doctors, the medical, maybe it'll get back all the way up into medical education, where as part of internal medicine training, part of rotation, they're advised of the increase in non-smoking lung cancer and taught what to look for earlier. My background is genetics, and then I was a life science healthcare venture investor for a long time, diagnosed with breast cancer, which then became sort of the next phase of my life, which has been working with women who are diagnosed with breast cancer. Now, unfortunately, a few of them have developed bone cancer and lung cancer. And so, but I've been part of watching what patient advocates can do. Look at the breast cancer situation, look at the Komen Foundation, look at rudense.com, which has changed laws around the country for early screening for the payment of ultrasound for women who have dense breasts, which never happened. When I was diagnosed, there wasn't the awareness that if you have dense breasts, that you could then, the mammograms were called happygrams. They didn't show the tumors. No one knew that. No doctor knew it. I was told, don't worry about that lump in your breast. You had a normal mammogram a month ago. But it took awareness, patients working with the medical community and patients banding together and forming organizations to just increase, the awareness and the funding and everything else. And so I would hope that from something like this, and, you being in the New York Times, and a lot of people, a lot of friends, a lot of women, a lot of people in the medical community saying to me, wow, this lung cancer thing in non-smokers is very real. I would think that there's something here where we could really move the needle forward with developing, some organizations that have an enormous impact. And I think the patient advocates It's sort of the building block to start from. That worked in breast cancer. It worked with AIDS. Look at the history of AIDS in this country. ACT UP. So that's all. I'm just encouraging that more meetings like this and people with your experience that, that you work tirelessly as you can. Thank you for being here and sharing your stories to raise awareness around this.
Thank you. That's a great note to end on. Lung cancer, I didn't realize until I was diagnosed as underfunded, massively underfunded relative to other major cancers. So we really need advocacy from patients like yourselves and caregivers to really move the needle on this disease. But thank you for your attention today. Really appreciate you sticking with us.